Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Hello and welcome. I'm Leanna McGuire, your host for this educational podcast, Heart Disease in Women, Risk, Prevalence, and Diagnosis by Elite Learning. Joining us is our subject matter expert, Dr. Joshua Weinstock. Dr. Weinstock graduated from Cornell University, after which he studied bioethics at the University of Pennsylvania before attending medical school as a member of the charter class of Cooper Medical School of Rowan University in Camden, New Jersey. During medical school, he served as a national leader of the American Medical Student Association and served multiple terms on the organization's board of trustees. After medical school, he completed an internal medicine residency at Cooper University Hospital, where he was awarded Resident of the Year in 2019 and served as a chief resident in 2020. He subsequently stayed on for cardiology fellowship training at Cooper. He has published research projects investigating cholesterol-lowering medication and another studying implantable cardiac monitors for detection of arrhythmia, presenting his findings at the Heart Rhythm Society National Meeting. Dr. Weinstock plans to work in the Philadelphia suburbs as a cardiologist, where he will continue to focus on cardiovascular disease management and prevention. Welcome, Dr. Weinstock.
Thank you so much. Thank you for the invitation. I'm honored to be here today.
Thank you. Before we dig deep into issues specifically related to women, can you tell our listeners exactly what coronary artery disease is?
Sure. So coronary artery disease is, one of the major diseases that kind of affects many in our population. It refers to atherosclerotic buildup of a cholesterol within the heart arteries as we age. And as we get older, the arteries build up with cholesterol deposits, atherosclerosis, and eventually, when that progresses enough, it can cause symptoms and very deleterious effects down the road, things like heart attacks. And so, oftentimes in the healthcare setting, we're seeing patients presenting with, either the symptoms or the unfortunate consequences of coronary artery disease.
And how does someone with coronary artery disease present in the clinical setting?
So the classic presentation, if you will, or the typical symptoms that we oftentimes hear about or see dramatized on TV, or the substernal, center of the chest pain. When we refer to typical chest pain, we're really referring to that kind of central chest pain, substernal discomfort that's brought on, provoked by exertion or other physical or emotional stress can also bring it on. And that typical chest pain is typically relieved by rest or medications such as nitroglycerin. So when we talk about kind of the classic presentation, we're really referring to, the typical chest discomfort that many people report. However, not everybody that is suffering from coronary artery disease or the consequences of coronary artery disease, like heart attack, for example, develops those same symptoms. And in fact, many people present with somewhat atypical symptoms, which I'm sure we'll touch on.
Yes. Okay, great. And sometimes I just wanted to differentiate before we move any further about angina. So can you tell us what the difference is between stable angina and unstable angina?
So angina is that kind of typical discomfort that I just mentioned. So it typically has those three features, meaning it's substernal mid-chest pain provoked by exertion or other emotional stress, better with rest, better with medicines like nitroglycerin. That's what we refer to when we're discussing angina. And that angina is caused by basically inadequate oxygen delivery to the heart cells, the myocardium. And when the myocardium is kind of starved of that blood supply due to the buildup within the coronary arteries, patients develop symptoms like angina. it becomes very worrisome when they present with symptoms of angina that are, not relieved by the traditional measures, things like medications like nitroglycerin, or by rest. And when it gets to that point, we refer to them as having unstable angina. And unstable angina actually falls under the kind of same umbrella as what many would consider to be the heart attack or the STEMI or the non-STEMI. We call those acute coronary syndromes when their patients develop acute discomfort, typically chest discomfort, and have evidence of end organ damage to their heart. We kind of place them in certain buckets. Acute coronary syndrome is an umbrella term, but we further define acute coronary syndromes typically by the features that are seen on EKG and sometimes other. So many people have heard of STEMI, and that's kind of the classic heart attack you hear of: ST segment elevation, myocardial infarction. That's typically the more serious presentation we see, where it's acute. Time is of the essence, and they're somewhat easier to identify because when you see patients presenting like that and with evidence of ST segment elevation on their EKG, we very quickly act. The other kind of acute coronary syndrome is what we refer to as non-ST segment acute elevation acute coronary syndrome, or NSTEACS, or NSTEMI is what many people refer to it as. That's where there may be signs of ischemia or inadequate blood supply to the heart on an EKG, but they're not showing that classic ST segment elevation that many of us are trained to identify. However, NSTEMI is defined by elevated cardiac biomarkers. And when I say that, I'm really referring to troponin, which is oftentimes checked in a healthcare setting. And when we see elevated troponins, that's generally a bad sign. And it shows that there is, damage to the heart muscle itself. And so when you couple EKG changes that are not elevations with elevated cardiac biomarker like elevated troponin, that is kind of what we refer to as an NSTEMI, or non-ST segment elevation acute coronary syndrome. But going back to your original question of stable versus unstable angina, unstable angina itself actually is distinct from STEMI and NSTEMI, but also worrisome and also treated similarly, where these patients, when they're declared unstable, meaning they're having the typical symptoms, they may have risk factors for coronary artery disease, and their pain is not relieved in the traditional sense, in the typical sense rather, those patients also, are treated more urgently and managed kind of similarly to the way you would patients presenting with NSTEMI or STEMI.
Got it.
When we talk about stable angina, like I said from the start when you initially asked the question, stable angina is more predictable. So there are many patients that we can manage who have, known coronary artery disease that we see in the office and are labeled as what we call chronic stable angina, meaning they do get chest pain from time to time. And it's predictable. They are able to mitigate that chest pain with the use of medications, so things like long-acting nitrates and other medications to prevent the angina or to suppress it. And when it's suppressed in that predictable manner and more of a stable state, we call that chronic stable angina. So going back to your original question of kind of defining stable versus unstable angina, that's the way I generally think about it. Unstable angina, very worrisome. Stable angina, not good, but can be managed chronically, and typically, with cardiology providers, we can manage that with medications in our, at our disposal.
Excellent. Great answer. Okay. Now let's talk about how women differ from men when it comes to heart disease. Do we present differently as well?
So the interesting thing is that some people may have heard that women present entirely differently. And while some of that may be true, it's actually most common that women will present with chest pain like their male counterparts most commonly present. So I don't want to paint a picture that women don't get chest pain, because many do, but some don't. And so there are some other, more common symptoms of heart disease that people generally don't want to ignore. So some people develop dyspnea, shortness of breath, particularly when it's exertional in nature, unusual fatigue. Overwhelming fatigue can be a symptom of coronary disease. Some patients develop pain in their neck or jaw. You'll oftentimes hear pain running down the arm. So many, some women will have those symptoms. And then, also we do see patients presenting with GI symptoms. So things like nausea, vomiting. Sometimes patients ignore their symptoms because they think, oh, it's just indigestion or something, when in fact, it could be an acute coronary syndrome, and it could be, that something more serious than just indigestion.
I've also heard of a silent episode. Can you explain that to us?
Yeah, so it's actually interesting. Sometimes we catch what we call silent myocardial infarctions or silent heart attacks. And that can be for a number of reasons, but sometimes patients will get an EKG and it'll show evidence of perhaps an old heart attack, maybe Q waves on an EKG, or, they'll have a nuclear stress test or something that shows an old area of infarction. And we do know that some people, for whatever reason, don't develop symptoms and may have an episode that goes missed for a number of reasons. Particularly actually in diabetic patients who, as we know, develop neuropathy in all parts of the body. So patients with uncontrolled diabetes, unfortunately, many times will develop peripheral neuropathies, but you can also develop neuropathies that affect the innervation of the heart. And so that may be the case for some of these silent, myocardial infarctions. So I guess the point of having this discussion is basically to say that, while some patients present with the classic heart attack that, is like I said, we see on TV where patients have that, crushing chest pain in the central of the chest, some patients don't have any symptoms, and some people have very, so to speak, atypical symptoms. So we always, when we're evaluating patients, need to have an antenna raised, to think about coronary disease, as even when patients present in a somewhat atypical manner.
Got it. Okay. And is it true that women are generally older than men when we present with symptoms, or have this come on for us?
Yeah. So in general, the way it's taught is that women in general present about 10 years later than their male counterparts. Wow. And the reasons for that are interesting. So women, unique to men, have some degree of hormonal protection from progression of coronary, or development and progression of coronary disease from estrogen. So women who are of childbearing age are protected a little bit by the estrogen that they have. Estrogen itself is a hormone that does a lot of things to the body, some of which do affect vascular tone and pliability of the vasculature. Estrogen affects lipid metabolism and other things. And so as women are going through their childbearing age years, they are offered some protection from the hormones throughout the body. As they enter menopause and the postmenopausal periods, that protection actually can go away. And it's during those years where women tend to catch up to their male counterparts and, are at further risk for coronary disease. So in general, women, we refer to premature coronary artery disease is kind of defined as somebody who has a relative who a male relative who develops coronary artery disease before the age of 55. But for females, it's a little bit different in the sense that coronary disease is considered premature when it's before the age of 65. So there's about a 10-year gap there where women eventually catch up to men. But so early on, there's some degree of protection. But overall, the burden of cardiovascular disease, particularly later in life, is high for both men and women. Got it.
So would this speak positively in favor of estrogen replacement therapy?
So that's a good question you asked. So the logical thought would be, well, if we were to give estrogen, replacement therapy or hormone replacement therapy to women, would we be able to kind of stave off that? And this has actually been studied. There have been some initiatives to study this in the past. And what they found is that it was kind of a mixed bag in terms of the outcomes of giving replacement therapy. So what they found actually, I believe the Women's Health Initiative studies studied this. And what they found was that the incidence of things like myocardial infarction and stroke actually went up for a certain portion of the population who received hormone replacement therapy.
Interesting.
And when they further looked at that data, it tended to be people who were later on in the postmenopausal years as opposed to the early postmenopausal years. But we also know that hormone replacement therapy affects not just the cardiovascular system, but the body in general. And we know that the incidence of things, like stroke, but also venous thromboembolism can go up. And so, as cardiology providers, we do not in general, routinely suggest that hormone replacement therapy is the answer here at all.
Right.
There are indications for hormone replacement therapy, but for coronary artery disease, that's not something that is routinely done by any means.
Got it. Let's talk family history. How does that play into that?
So family history plays a big role, unfortunately, because there's a lot of risk factors that we can change and ways we can minimize or lower our risk. Genetics, unfortunately, we can't change. So we know that patients who are predisposed to coronary disease need to be a little bit more cautious. Now, almost everybody can identify somebody in their family who's probably had coronary disease or had an MI, things like that, because it's so common. It really affects us. Be hard pressed to find anybody who wasn't affected by this disease in some way, shape, or form, be it a close relative or friend. But like I said before, what is worrisome is when it's in a relative at a premature stage in life. And so again, what's considered premature is a man before the age of 55 and a woman before the age of 65. So let's say somebody had a family history of, a father having an MI at age 40 or a mother having an MI at age 50. That would be very concerning. And that would be somebody who would want to, do whatever they can to minimize the risk, and try and work on all the modifiable risk factors that they can to try and, mitigate and minimize their risk. Like I said, unfortunately, we can't change the family history. We can't change our genes, but we can work on other ways to lower our risk.
And what are some of the modifiable risks for women? Well, for either, but women it would be the same, I guess.
Sure. So there are a lot of modifiable risks. We can go into detail on many of them, but and a lot of them are fairly obvious, but we'll review. So, number one, smoking is very bad. I don't really that's not going to come as a surprise to anybody listening to this, but smoking obviously is bad for the heart, bad for the body. So for smokers, cutting back on smoking. Lifestyle plays a role. So if you're somebody who leads a sedentary lifestyle, building physical fitness in is paramount. That's something we can work on to improve outcomes. And then other, comorbidities, things like hypertension, hyperlipidemia, diabetes, we can work to optimize those conditions. So patients who may have risk factors for coronary disease, if they have high blood pressure, we can work to optimize their blood pressure. If they have hyperlipidemia, we can work to lower their lipids, to get them more controlled. And same for diabetes, we can work, to lower blood glucose and hemoglobin A1C levels. And doing all of that will lower, the long-term risk of coronary disease, or for patients who have known coronary disease, will work to improve outcomes. Let's see. So we touched on smoking. We talked about lifestyle. We talked about, some of the diseases that we can work on. Weight plays a role. So trying to be at a normal or healthy weight is important. And then diet plays a role as well. So there's a lot of modifiable risk factors, that we can work on. Unfortunately, genetics is something we can't change.
Good point. Now, if the incidence increases after the age of 65, is it still worth modifying at, say, 60 or 62 or 3 or 65? Is it still worth? Is it going to make a difference? Good to know.
Absolutely. 100%. So for our patients who are at the highest risk, those who we're working more on secondary prevention for. So a patient who may have already had a heart attack, who has known coronary artery disease, those are the patients that need to be, paid the closest attention to. And we don't raise the white flag and say we're giving up here. Those are the patients that need strict control of their lipids, strict control of their blood glucose. They need strict control of their hypertension. They need to, for patients who are post-MI, enroll in, cardiac rehab, work to, become more active. Those are, we can definitely improve outcomes, regardless of age, actually, and regardless of what, how far along people are in their disease process.
Good to know as well. Excellent. Now, let's talk about prevalence. Where do we stand as women in with heart disease being a cause of death?
Sure. So, interestingly, and unfortunately, the number one cause of death in this country for both men and women is cardiovascular disease. And so that's pretty staggering. And actually, a lot of women, don't even, men and women don't realize that. But, I think it's important to say that out loud and acknowledge that coronary disease is the number one killer of men and women in the United States. For women in particular, the numbers vary on a population level, but in general, at least 1 in 5 women will die from coronary artery disease. Wow. And I've seen statistics that suggest even 1 in 4 or as high as 1 in 3 will die of coronary artery disease. And so it is really staggering, the burden of cardiovascular disease in this country. And so it's something that we need to acknowledge and work to educate our patients on as providers, to make sure that everybody understands, how important it is.
Okay. I'm going to throw this question at you as a clinician, as a nurse, and obviously that's who's listening to our podcast. Oftentimes we get the response when we do bedside teaching about coronary artery disease and the risks and changing their lifestyle. Inevitably, someone will say, well, I had an uncle who jogged 2 miles a day and did everything right and dropped dead at 70. So what difference does it make? What's a good response for someone like that? Is that more of a genetic, you can go the genetic route, or?
It's tough to say. I mean, unfortunately, some people do all the right things and have a bad outcome. We've all seen that. And sometimes we don't know, the exact cause of someone's, demise. But, like I said before, that doesn't mean we give up on kind of working on all these things. I think it would be the wrong thing, to suggest that, we know that we have a good, very solid evidence base for all the things that we do in cardiology to know that there are benefits to, all the treatments that we provide our patients. And so, unfortunately, people that do all the right things, do have heart attacks. And some of that is not, completely understood, but we do the best we can to optimize our patients. And, the hope is that in optimizing them, that we lower the risk. The risk, for anybody is never zero. Things happen. But, we would like to lower those risks as much as possible.
I guess we can always fall back on the evidence and research. Excellent.
Yeah.
Okay. Now, let's talk about diagnosis. What's the best practice when it comes to women? Starting with, say, a stable patient comes in with chest pain.
Sure. So first of all, it's very important that, women and men, establish with good providers. They need to, especially when they're having symptoms, be evaluated, particularly when they're having symptoms like chest pain. But also, as we discussed, some patients have atypical symptoms. So if something's not right, you need to be evaluated. And that's really the starting point. We like to, of course, focus on prevention, but if you're not feeling well, we need to, to address that. But for a stable patient in general, who may, be having symptoms, a lot of the initial management is done with things like getting a set of vitals in the clinic, doing a physical exam, getting an EKG. Those are really all the ways we kind of start to go about working up coronary artery disease. For patients who may have some risk factors, and if they are having symptoms in particular, that may be an indication to proceed with a stress test. And so oftentimes for those stable patients, we'll proceed with things like stress testing. That may be an exercise stress test, by exercising on a treadmill. For patients who can't exercise, it may involve a pharmacologic stress test, where, we give medication to accomplish, an ischemic workup. And for other patients, actually, especially nowadays, we're using CT. Actually, has been a good modality, CT coronary angiography, to look in a non-invasive way at the coronary arteries, or CT calcium scans to assess, the calcium burden in the arteries. Those are all ways for our stable patients that we can work them up. Taking a step back, other things like checking a lipid profile, checking an A1C, for patients. Those are ways we can focus on, diagnosis and prevention and all that. That's really key. The unstable patients, when it gets to that point, diagnosis is a little bit trickier and unfortunately a little bit more risk. There's a little bit more risk involved because when you're presenting, with things like an acute coronary syndrome, then, we really oftentimes are committed to doing coronary angiography on those patients through means, oftentimes like a cardiac catheterization which is the gold standard to kind of go in and look at the coronary arteries and assess them. We also, can use non-invasive modalities in that setting as well, but most commonly, especially for STEMI or NSTEMI, those patients are, in most cases, going to go to the cath lab where we'll, assess their coronary arteries. And oftentimes, if there's a problem, it can then be addressed if, they're found to have a blockage.
I want to go back just for a second to the genetic factor. And I think I already know the answer to this, but I'm going to ask it. I think it, begs being asked, but one way or the other. When you have a genetic risk factor, as a woman, are you more susceptible if you inherit that from your mother's side, or does it matter which side it comes from?
It's a great question, actually. In general, it doesn't really matter. A lot of these conditions are inherited irrespective of whether it's a mother or father's side. So I would say it's important that we identify a family history, but it's less so important for most cases which relative it came from. But there are exceptions.
I had the right answer in my head. I'm always glad when that happens. Now, another question, and this may be something that you're aware of or not, but I know that I remember seeing a billboard one time that said the biggest killer for men is denial. It's like a stereotypical in a way that they don't want to go to the doctor and they deny what's going on. Do you find the same thing with women, or are they more open to, hey, I'm not feeling well, I need to go now?
I think, so I've seen patients kind of both, hopefully patients when they don't feel well will present to their doctors and be evaluated appropriately. Some patients, though, do mistake. I've seen many times where patients, again, using the indigestion as an example, where they, thought they had a stomach bug and then they present late and then they're found to have an MI. And then that can subject, when you present late in general, the outcomes tend to be a little bit worse as opposed to being, addressed early on. And so the stereotypical, I guess, men being reluctant to seek care, I think we see it, unfortunately, with both men and women sometimes. But the outcomes in general tend to be worse when symptoms are ignored. So the whole point is we need to be chatting with our patients about, really, if something doesn't feel right, being evaluated.
Right. Okay. Well, that's all the time we have for episode 1 on heart disease in women, risk, prevalence, and diagnosis with our subject matter expert, Dr. Joshua Weinstock. Thank you for joining us. And we will be back with episode 2, where we'll look more deeply at diagnosis and talking about how to reduce those risk factors and interventions. This is Leanna McGuire for Elite Learning by Colibri Healthcare.
This podcast featured content from an accredited CE activity provided by Colibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.